So continuing with the lateral wall. The lateral wall is triangular in shape, perpendicular to each other. The two lateral walls of the two orbits are perpendicular to each other, formed by the two bones that is the interior zygomatic bone and posteriorly by the greater wing of the sphenoid, and it separates the orbit from the middle cranial fossa and the temporal fossa. Okay, the anatomical landmarks. The anatomical landmarks of the lateral orbital wall are the lateral orbital tubercle, also known as the tubercle of Wicknall. It is a small elevation about 11 mm behind the frontozygomatic suture, 11 mm behind the frontozygomatic suture, and it gives attachment to the check ligaments of the lateral rectus, suspensory ligament of the eyeball, and the aponeurosis of the LPS. On the posterior part, there is a small bony projection known as spina rectus lateralis, which gives origin to the part of the lateral rectus muscle. The applied anatomy of the lateral wall is it protects only the posterior part of the globe and not the interior part of the eyeball. Hence, the palpation of the retrobulbar tumors is easier from the lateral side than the nasal side. Since the lateral wall is almost devoid of the foramina, bleeding is very less. Hence, lateral orbitotomy is preferred out of the medial orbitotomy. The zygomatico-sphenoid suture, important landmark in creating the flap in the lateral orbitotomy. The zygomatico-sphenoid suture. This suture is an important landmark. The roof of the orbit, it underlies the frontal sinus and the interior cranial fossa. It is formed by the frontal bone, the orbital plate of the frontal bone, the lesser wing of the sphenoid. It is also triangular in shape. It faces downwards and slightly forwards. The landmarks in the roof are the lacrimal fossa. It is located at the anterolateral. Part of the roof, and it lies behind the zygomatic process of the frontal bone, and in this the lacrimal gland is situated. The trochlear fossa, it is a pulley of the superior oblique muscle and is situated at the junction of the roof and the medial wall. The roof is thin and the periorbita of the roof peels away easily. The objects piercing the upper lid penetrate the roof and damage the frontal lobe of the brain. In the old age, roof may be absorbed so that the periorbita and the dura mater comes in contact with each other. Any trauma of the dura mater and the CSF escapes into the orbit or nose or both because of the old age. The orbital margins. See, this is the superior orbital margin. The orbital margin is formed by the rim. This is also single rim, the lateral orbital margin, the inferior orbital margin. But the medial orbital margin is not a single margin. See, this is the one thing. See, this medial margin is formed by the two rims. This is the posterior lacrimal crest. This is the interior lacrimal crest. In between the lacrimal fossa. Okay. The next. The supraorbital margin is formed by the orbital arc of the frontal bone. The supraorbital notch is present at the summit of the arc and transmits the supraorbital nerve and vessels. The supratrochlear groove is 10 mm. The supratrochlear groove is 10 mm medial to the supraorbital notch about here, transmits supratrochlear nerve and the artery. The supraciliary canal, it is present in just 50% of the skulls. It is an opening near the supraorbital notch. It transmits a nutrient artery and a branch of supraorbital nerve to the frontal ear sinus. Okay. Lateral orbital margin is the strongest part of the orbital outlet. It is formed by the zygomatic process of the frontal and the zygomatic bone. The inferior orbital margin is formed by the zygomatic bone and the maxilla, and both of them contribute equally. There is the inferior orbital margin which was formed by the the inferior orbital margin, which was formed by the zygomatic bone and the maxilla, and both contribute equally. The infraorbital foramen, which is halfway along the margin, 4 to 5 millimeter below the margin, it transmits both the infraorbital artery and the nerve. The medial orbital margin is formed above. The medial orbital margin is formed above by the frontal bone, interiorly by the lacrimal crest on the frontal process of the maxilla, and posteriorly by the lacrimal crest on the lacrimal bone. The apex of the orbit consists of the optic canal and the superior orbital fissure. This area is the apex of the orbit. The optic canal, the measurement of the optic foramen is, it is 6 to 6.5 mm vertically and 4.5 to 5 mm horizontally. More than 7 mm in size. It is present when the optic foramen enlarges abnormally in the optic nerve gliomas. The optic foramen opens into the optic canal, which is 8 to 10 mm long and 5 to 7 mm wide. It is located within the lesser wing of sphenoid, the optic canal. It is separated from the superior orbital fissure by the bony optic strut. The optic canal attains the adult dimensions by the age of 3 and is symmetric in most patients. The optic canal connects the orbit to the middle cranial fossa. Structures passing through the optic canal are the optic nerve and its meningeal coverings, the ophthalmic artery, and the sympathetic nerves. The superior orbital fissure is also known as sphenoidal fissure because it is located between the greater wing of sphenoid and the lesser wing of sphenoid. And the lesser wing of the sphenoid is a part of the roof of the orbit, and the greater wing of the sphenoid is the part of the lateral wall of the orbit. The superior orbital fissure is 22 mm long, and it is the largest communication between the orbit and the middle cranial cavity. The annulus of Zinn. It encircles the optic foramen and the central part of the superior orbital fissure, dividing the superior orbital fissure into upper, middle, and lower part. Upper, middle, and the lower part. In the upper part, the structures which pass are the lacrimal, frontal, and the trochlear nerve, to be remembered by the acronym LFT, and the superior ophthalmic vein. The structures which pass through within the annulus of Zinn are the 3, 5, 3, 6, that is the superior and the inferior division of the oculomotor nerve. The fifth nerve, the nasociliary branch, is between the superior and inferior division of the oculomotor nerve, and the sixth nerve, the abducens nerve, is also passes through the middle part of the superior orbital fissure. From the inferior part of the superior orbital fissure passes the inferior ophthalmic vein. The clinical application. The radiographic enlargement of the superior orbital fissure may accompany many pathological processes such as aneurysm, meningioma, choroidoma, pituitary adenoma, or the tumors of the orbital apex. The paracellular syndromes. The paracellular syndromes are due to inflammation due to adjacent sinusitis, which can be bacterial, viral, or fungal, which cause orbital cellulitis and the septic emboli, due to neoplasia, either meningioma, pituitary adenoma, trauma, non-inflammatory causes such as pseudotumor and sarcoidosis. The paracellular syndromes includes the superior orbital fissure syndrome and the Tolosa-Hunt syndrome. The superior orbital fissure syndrome, it consists of the neurological disorder that results in the superior orbital fissure is fractured. Involvement of the cranial nerves that pass through the superior orbital fissure may lead to diplopia, paralysis of the extraocular muscles which are supplied by these nerves, exophthalmos, and causes. When idiopathic inflammation involves the superior orbital fissure, the Tolosa-Hunt syndrome results. This is a painful ophthalmoplegia due to the idiopathic inflammation involving the superior orbital fissure. The inflammation is typically non-specific granulomatous inflammation of the cavernous sinus, superior orbital fissure and the orbital apex. And the pain in this syndrome results from the inflammatory involvement of the first division, that is the ophthalmic division of the trigeminal nerve. The inferior orbital fissure lies between the lateral wall and the floor of the orbit. The infraorbital fissure is 20 mm bony defect bounded by the sphenoid, zygomatic, maxillary and the palatine bones. Okay, it communicates the orbit and with the inferior temporal fossa and the pterygopalatine fossa. The structures passing through the inferior orbital fissure are the infraorbital nerve, the zygomatic nerve, the parasympathetics to the lacrimal glands, the infraorbital artery and veins, and the inferior ophthalmic vein. The connective tissue system of the orbit will be discussed in the next video.